The following is a narrated presentation of the key concepts and figures contained in Chapter 412 in the 8th edition of the textbook, Humans and When Neurological Surgery. I am Paul Garcia. Innovations in neurosurgery heavily rely on advancements in anesthesia care. Over 60,000 patients safely undergo surgical anesthesia daily in the United States. In the early days of anesthesia care, intraoperative monitoring was primitive, and the major concerns were avoiding catastrophic events such as sudden cardiopulmonary failure. Historically speaking, surgeries were rarely carried out on patients with severe comorbid conditions. At that time, it was assumed that while under the care of an anesthesiologist, the anesthesia medications were fairly safe, and that all patients reacted to these medications in much the same way. As our monitors evolved, we continued to increase the number of surgeries and procedures on patients with more complicated pathophysiologic conditions. Eventually, intraoperative catastrophe became less prevalent and concerns shifted towards delivering personalized and optimized health care. The modern perspective of most anesthesiologists is that for every drug administered, we should target a specific therapeutic dose optimized for both patient and clinical situation. The end target organ of anesthesia care is the central nervous system. The electroencephalogram, or EEG, is a convenient, non-invasive method for assessing brain neurophysiology in real time in order to titrate analgosedative agents. The top trace in this figure depicts 4 seconds of EEG data recorded from scalp electrodes over the frontal cortex in a healthy patient receiving general anesthesia. The bottom trace demonstrates a subtle increase in higher frequency oscillations that appear after surgical stimulus begins. Most FDA-approved devices for titration of anesthetic drugs utilize an abbreviated electrode montage, as compared to the classical 1020 system used in epilepsy monitoring. Here is a picture of a disposable sensor from one of these devices. This sensor has 4 electrodes. It is placed on the forehead and can be used to track the hypnotic state of that patient. Shown here is 2 10-second frontal EEG recordings of a patient receiving an excessive dose of anesthetic agent. Notice the classic burst suppression pattern. It is characterized as discontinuous periods of isoelectricity. In this state, the cerebral cortex alternates between electrical suppression and bursts of intense synaptic activity. Most of these EEG-based devices reduce the EEG information into a single number intended to represent a universal metric for arousal. However, this approach has been criticized, and a more modern perspective is to evaluate both the raw time series signal as well as the spectral features using quantitative EEG in order to form a more complete picture of the neurophysiologic features of the anesthetized brain. At least 4 distinct frontal EEG patterns have been determined to commonly occur in patients undergoing surgery with general anesthesia. All of these patterns are easily distinguished from the awake EEG as they show little high-frequency activity and are dominated by oscillations in the lower frequency ranges. Each pattern possesses specific differences in the distribution of low-frequency power. Delta-dominant slow-wave anesthesia, DD-SWA, can be distinguished from spindle-dominant slow-wave anesthesia, SD-SWA, by the absence of alpha oscillations. Non-slow wave anesthesia, NSWA, is characterized by an overall reduction in EEG amplitude, and burst suppression is easily recognized by its discontinuous episodes of isoelectricity and bursting. Several factors can affect transitions among these frontal EEG patterns, including anesthetic dose, age, cognitive frailty, intraoperative noxious stimulation, physiologic derangement, and drug choice. Specific trajectories have been identified that confer improved postoperative pain control and less confusion during postoperative recovery. As we learn more about the neurophysiology underlying the reestablishment of consciousness, clinicians are forced to reevaluate the terminology we use to classify abnormal recovery patterns after surgery with general anesthesia. This is especially important in neurosurgery, where a reliable postoperative neurologic exam is critical for clinical decision-making. Simple clinical assessments can be used to determine if a patient is sedated and confused or simply sedated. If the patient is unresponsive, they should be considered unconscious and not delirious, as delirium is characterized as a disorder of consciousness, not the absence of it. Although it is known that incident delirium can exacerbate cognitive dysfunction in patients at risk for neurodegenerative disease, it remains to be seen if avoiding perioperative neurocognitive dysfunction confers any long-term neuroprotective benefit in at-risk patients. This remains an active area of investigation among neuroanesthesiologists.